blood products, thoracentesis, extubation, Levophed, central line placement, all in 12 hours. Welcome to the ICU. Hi guys, welcome back to the Mama Nurse channel. I'm Vanessa, and today we're going to talk about my first 3 days back after maternity leave. Don't forget to subscribe to my channel where you're going to hear all things nursing and all things motherhood. So as I spoke previously, I recently went back to work after my 12-week maternity leave. Honestly, coming back from maternity leave, I didn't remember anything. It's so hard when you go such a long period of time without doing those hands-on nursing skills or even thinking about nursing. Nursing is really a muscle memory type of profession. Of course, you have to have the smarts to do it as well, but when you're not using those skills for a period of time, you do feel like you forget it. So walking into the building on my first night, I was in a daze. I didn't know what was going on, what to do, and that's just typical. Once you get back into the swing of things, of course, it just comes back to you naturally, but that first day, you almost feel like a new grad again. Coming back from this maternity leave was kind of bittersweet, only because I knew a lot of my coworkers were no longer on that unit. For different reasons, they've moved on to bigger and better opportunities, had babies, or whatever the case may be. So a lot of the friendships and bonds that we had formed, those people weren't going to be there when I went back. So that kind of made it less happy of a return, I guess I could say, because I knew that they weren't going to be there. There are still definitely a few of my coworkers that are still there that I'm happy are still there. We just help each other out throughout the shifts, and it makes it easier when you have somebody that you could run to real quick or just chit chat for a quick 5 minutes. So I had my 3 night shifts straight. My first 2 nights were easy peasy. Night 1, I had 2 stable patients. One was vented. They were planning on possibly withdrawing that person a couple days later. I had a 3rd person who was a little restless but was manageable. Night 2, I was 1 and open. So basically I had 1 patient and my other room was open for any admission traumas that came in. I ended up getting a patient at about 2 a.m. So from 7 p to 2 a.m. I only had 1 patient. So I was around the floor helping other nurses. And now night 3. So on night 3, my assignment ended up getting changed. We have a lot of new grads on our unit now. And if you don't know, I work on a Trauma Surgical ICU. So the 2 patients that I did have ended up being pretty stable. And once they had broke me in and got me back from maternity leave, they kind of gave me my first 2 nights easy. 3rd night, I hit the ground running. I had 1 patient that getting report I already knew was going to be busy. She was going to be getting blood products. She kind of took a turn for the worse during the day. So I knew she was going to be busy already. About 8 o'clock, my charge nurse came over and said that my 2nd patient was coming. It was going to be a Halicat that they had called probably at about 7:45 that night. So I had my 1 patient that was unstable already, and then I was getting a Halicat. That Halicat that was coming, the blood pressure was in the 70s over 40s. So obviously that patient was going to be heavy load as well. So of course my charge nurse gave me the heads up, so I knew that I needed to get everything I could get done on my first patient that was already there, because once that Halicat came, I didn't know how long I was going to need to spend time with that patient. So I went in, I did my assessment, I did all the little tasks that I could do in that little bit of time, because it's in the same building, so they probably came down about 5 to 10 minutes later. So I did her assessment, got her temperature, all the little things that I typically do at the start of my shift. The only thing I didn't do were her medications. She didn't have anything that she needed urgently, so it was okay to wait, because I knew if I had started to do the Medpass, I wasn't going to finish before that other patient came, and you never want to leave your medications unattended. So I decided to hold off on that, and I knew I would be able to go back in a timely manner and get that done, or ask my coworkers to pass those meds if needed. So for the purpose of this video, we're going to call patient 1 Jane. She was a female, and patient 2 is going to be John. He is a male. So John came down to the unit. He was originally on one of the med-surg units. On assessment, his blood pressure at the time was 69/35. So he had a liter bolus that was already infusing, and our intensivist had ordered a total of 3 liters that he wanted to be given. And only had 1 IV site, so we immediately placed 2 other IVs. We had to get blood work, CBC and a chemistry panel, as well as a lactic acid. So if you don't know lactic acid, you know that has to be on ice immediately, and you have to send it down to the lab. So we did everything to get him set up and comfortable. We have a pretty good team on our unit, so while I was getting report, they didn't do report over the phone. We did it at bedside, only because in urgent situations like that, they'd rather get the patient down to the ICU just in case they take a turn for the worse. Our intensivists are right there and we can get things done. So while I was getting bedside report, there were a couple other nurses in the room that was doing the CHG bath, which just helps to prevent infection while you're in the ICU. So they were doing that, getting his temperature, his weight, and before I stepped out to get bedside report, I did a quick neuro assessment just to get his baseline and see what exactly I was working with. He was ANO ×3, he was just very lethargic. So once I got report, I went back in and up the 3-liter bolus. He had his new IV sites. His blood pressure at this time was in the 80s/50s range. So our intensivist came up at that point. He decided that he was going to want to place a central line. So we got our central line cart. Possibly also going to do a lumbar puncture. Upon talking to his wife, the patient had had some confusion over the last couple days. He was very lethargic, spiking fevers here and there. So they wanted to rule out meningitis. After further workup, the doctor decided that he could hold off on the lumbar puncture. It wasn't a dire necessity to get it done right at that moment, so he said that he would hold off on that and just do the central line placement at that time. So we did call his wife and get phone consent. So you know, with phone consent, you need to have 2 nurses to verify the information and get the okay from that healthcare proxy or next of kin. So because the patient's blood pressure still wasn't adequate, the MAP was still below 65, the doctor went ahead and ordered Levafed. That's a vasopressor to help increase the blood pressure. So you can start Levophed at a very low dose through a peripheral line for a small amount of time, just until a central line is placed. If you cannot get a central line on a patient, then they cannot be on Levafed because it will cause that necrotic extremities and very harsh medication, so you definitely want to have it going through a central line. Prior to placing the central line, the doctor did order 2 of morphine, so I went ahead and gave him 2 milligrams of the morphine. We had the Levafed going at a very low rate. He already had his 3-liter bolus, so now it was time for the central line placement, which is a sterile procedure. He went in through the right subclavian, and it was a successful first attempt. Went ahead and put the dressing on. X-ray came by to confirm placement, and I went ahead and switched the Levafed over to the central line once my doctor went ahead and checked those results and made sure that it was okay to use. So once the central line was placed and the Levafed was going through the central line, the doctor was still making a lot of changes when it came to his medication regimen and antibiotics that he was on. So I made the decision to go ahead and go back to patient number 1, which is Jane, and do her Medpass for the night. So Jane needed platelets from day shift, but they weren't yet ready. So when I went in to do her Medpass, I went ahead and had the tech go down to pick up the platelets for me so I could get all of that done at the same time. So platelets can infuse fairly quickly, so I wasn't really worried about that taking up too much time. So I did Jane's Medpass, I gave her her platelets. Now it was time to go back to John. At this point, John was on 4 of Levafed. His blood pressure was slowly improving, but it was dipping here and there. I went ahead and did all of his antibiotics and everything else that the doctor had ordered for him. I had to draw labs on Jane. So I went back, drew some labs. This was later on after she had gotten the platelets. When those results came back, we realized that her hemoglobin had dropped. She had previously had a GI bleed, so it seemed like it was starting up again. Her hemoglobin was 7.8. So the doctor went ahead and ordered 1 unit of PRBCs. So we started that process. Jane was vented. She was fairly young, so the doctor wanted to go ahead and see if she would be a candidate for extubation. So he got the ultrasound machine, see if she still had fluid in her lungs. So she did. She had previously had 2 chest tubes, both of which were at this point out, but she did still have some fluid in her lungs. So he went in and we did a thoracentesis at the bedside. He removed 650 mLs of fluid from her right lung, and we did send that down, a specimen down for a workup. Once that thoracentesis was complete, we went ahead and switched her over to CPAP on the ventilator in order to see if she was able to breathe on her own, check her readiness for being extubated. She stayed on CPAP from about 1:30 a.m. until 5:52, and that is when we extubated her. During that time, we were doing our routine care. Did get her 1 unit of PRBCs. Respiratory did come by and do what we call parameters to see if she has good numbers for the extubation. Numbers were good, so we went ahead and pulled the tube. She was placed on nasal cannula, but it was still a little bit difficult for her to keep her O2 saturations elevated. So we went ahead and put her on high flow, and she was satting about 94 to 95%. When a patient is first extubated, you do want them to try to cough up any secretions that they have. You want them to try to talk, because the more that they do that, the better their chances of staying extubated are going to be. If they sit there and hold on to those secretions and they don't want to talk, even though it might be a little bit painful just because of the swelling that might be there, then they run the chance of getting re-intubated. So she was doing fairly well. Her voice was getting stronger minute by minute, and she was working on her cough, but she definitely had a lot of work to do with the coughing. So since she was now extubated, I went ahead and called her mother to give her an update. She was ecstatic. We made plans for her to be able to talk to her daughter later on during the day shift in order to hear her voice for the first time since all of this occurred, and she was really excited about that. So by the end of my shift, I was able to titrate John down off of the Levophed. I paused it at about 5:15 that morning, and I had gotten him down to 2 of Levafed, and then it was paused from 5:15 up until when I left. So anytime somebody is on a drip, especially something as strong as Levo, you do want to try to titrate it down if you can. You don't want to give a patient more than what they need. If they get to a stable point, then within protocol of titration, you can get it to the point where it is either off or paused for a certain amount of time so that you could see if the patient is still stable without it. So all in all, my 3 shifts, I won't complain. The first 2 were very chill, just kind of going with the flow. The third one, I was running all night, but honestly, I love it. That's part of nursing. That's why I became a nurse, to make sure that I can help my patients and to stay busy so that I don't get bored. Another plus, one of those shifts was an OT opportunity, so I got a nice little bonus. All right, guys, so that's it for my first weekend back from maternity leave. Stay tuned for more nursing content now that I have my nurse hat back on. I hope you enjoyed this video. If you have any questions, go ahead and drop it down below. If there was something that I didn't explain to the point where you could understand it, feel free to let me know and we can discuss it. Until next time, stay safe, be well, and live life.